Hi, everyone. Welcome to the Sign Ask the Neurologist podcast series. My name is Sahdev Baweja. I'm one of the e-board members on Sign, and today I have the pleasure of interviewing Dr. Dohle. She is the section chief of inpatient neurology, as well as the director of quality. Dr. Dohle, thank you so much for coming on today.
No, thank you for having me. It's a pleasure.
So could you tell us a little about your journey to where you've come today as the section chair and also the section chief, as well as the director of quality?
Yeah, of course. So I did my medical school in Germany and graduated from the Ruhr University of Bochum in Germany. And after medical school, I thought that I really wanted to do into basic science research. So I spent a year and a half as a postdoc at Yale in a lab, worked on the chemo regulation of breathing, and realized that I was really missing, though, the human connection, and decided to do my residency and did my neurology residency at Yale. And then I thought, what do I want to do afterwards? And what I really liked was the aspect of neuroplasticity, specifically after stroke. So I chose to go into a fellowship for neurorehabilitation, where I focused on the rehabilitation of stroke patients, spinal cord, and patients with TBI. I did that at Burke Rehabilitation Hospital in White Plains, New York, which was at the time part of Cornell, and is now part of Montefiore Hospital System. And during my time in the rehab realm, I also learned a lot about the quality of care and about the necessity to monitor the quality of what we are doing. It's not so much just about the medical algorithms, but really about the overall quality of care that brings out the best care for the patient. And during my time in rehabilitation, I really enjoyed it. And then I wanted to be more involved in the inpatient setting. So I took a position at Westchester Medical Center, where I am today. And my role here is to build out the neurohospitalist role in the inpatient neurology setting, and also monitor the quality of the care that we are giving to our patients.
Thank you. So before we talk a little bit about what you do currently, was there any other fields besides neurology that you were considering going into?
Yeah, initially I thought I would be a pediatrician. So all my life I thought I would be a pediatrician. And then I went to medical school, and I had this professor who would talk to us about his patients. He would give lectures. And in Germany, a medical school is very lecture-based with some clinical exposure. It's a little different than here. But I remember those lectures, I was at the edge of my seat about these patients. It was so interesting. Neurology is a lot like Dr. House. People come with symptoms, and they could really mean anything. And you have to take into account their history. You have to take a very careful history and a very careful exam. And then the MRI is usually, it should confirm what you're already thinking. But I thought it was just so interesting, and I love neuroscience. So that's what swayed me into going to neurology.
Okay. So as a neurohospitalist, what type of patients do you see? What type of diseases do you treat?
So in the inpatient setting, I see all comers with neurological illness, except stroke. So in our setup, it is such that the stroke team sees polycystic patients from admission all the way to discharge, and the neurohospitalist sees what's called general neurology. However, my realization is that our patient population is so complex. There's very little general neurology. Everybody has some complexity of their case. So we see a lot of neuroimmunological diseases. We see a lot of autoimmune encephalitis, a lot of paraneoplastic illness. We see a lot of seizures, new onset epilepsy, and the occasional brain tumor. So those are the main diseases that we see on the general neurology service.
And would you say most of your patients are like elderly, or do you see children to adults?
So child neurology, if you're interested in pediatric neurology, that's a decision to make from the get-go, because it's a different path in residency. If you would consider to be a pediatric neurologist, I strongly urge you to actively seek out an elective with a pediatric neurologist, because your residency application and your residency path will be different from the beginning. As a neurology graduate, I see adult patients, so 18 and older, sometimes 16 and older, but most of our population is they get younger every year, I get older, so they're not that old anymore. And they tend to be, I would say, 40 to 60 is kind of our sweet spot. We see some younger patients, especially again with the MS, the Guillain-Barré, the neuroimmunological illnesses. We see frequent younger patients, like younger than 40. That's young to me. And and then of course we have patients on the older spectrum. I would think, just in my personal experience, that maybe the stroke team has more of a focus on the elderly, because your risk of stroke increases the older you get. Our population in general neurology is 40 to 60, I would think, is our common population.
Okay. And these next questions will be talking a little bit about just your day-to-day life. So what would you say a typical day or a week in your life is like?
So at this point, I want to put a huge plug for Neurohospitalist Life, because a lot of neurologists, there was actually a discussion at the AAN about this need in neurology to like specialize from the get-go. It's like you go into neurology and people are like, oh, do you want to do movement disorder? Do you want to do stroke? What do you want to specialize in? And there's really a big need for inpatient neurologists supervising the care of the neurological patient. And my day-to-day life is, when I'm clinically active, when I'm on service, that I meet with the residents in the morning and we go over our patients. We do table rounds. That's a personal preference from me. Some of my colleagues, when they're on service, they do walking rounds, and we discuss what happened to the patient overnight, what their treatment plan is. We discuss the new admissions. We do have a hard stop at 9 a.m. where we meet with the rest of the care team, because in medicine, you're never just by yourself, right? It's never just a doctor treating. There's nursing, there's casework, social work, PT, OT, speech. And the more you communicate with those members of the team, the better the care that you give. So at 9 o'clock, we have what's called interdisciplinary team rounds. So we stop everything, we go there. We talk about the patients, what their needs are, what their discharge plan is, how we can optimize them to get them, prepare them for discharge. And then we resume our rounds and we see our patients and see our, the patients that are already on service and the new admissions, prepare for discharge. And in the afternoon, then we usually take a break just to make sure that the residents have time to implement the care plans that we have developed. And then in the afternoon, we meet again, go through the list. We often have some type of teaching discussion about interesting cases. And that's my day.
Okay, and is it like a 7 on, 7 off schedule, or how is your schedule?
Here at Westchester Medical Center, we do not have 7 on, 7 off. The medical hospitalists have that system of 7 days, 7 to 7, 12-hour shift, 7 days, and then 7 days off. Since we don't have that many neurohospitalists, we don't have nocturnists at night who would cover the night call. So for me, when I leave, I have my phone on, and when the resident has a case in the ER or questions on the unit, they do call me. It's a little bit, some nights can be busy, some nights can be not busy at all. So it's a little bit up and down. But because we do take that night call, we don't have the 7 on, 7 off model, because we don't have, if I would sign off after 7 o'clock, we wouldn't have enough, staff to then be on for the night shift.
Got it.
Yeah. Neurology is a little bit smaller department than medicine.
Okay.
But there are in other hospitals with different staffing models. There is the model of 7 on and 7 off is definitely out there. And when we are looking to hire, we had a couple of people, potential prospects, who are asking about this kind of model, because for some people's work-life balance, it works better. And so the other part of being in this neurohospital world is that usually you can find a model that kind of works for you. Usually the hospitals will work with you to develop a model that works with your life balance.
Okay, and how would you say your work-life balance is overall, or how do you maintain it?
I think it's pretty good. When I'm on service, I enjoy my work. That's always helpful, right? You want to have work that you look forward to going to in the morning. I like the team. That's a big part of it. And when I leave here, I'm usually able, even if my phone is on, I'm still able to kind of be present with my family. So what helped me in the past is to make sure I remember to be present when I'm outside the hospital and really kind of try to be present in the moment with my family. I like to exercise and garden. I don't know if that makes me sound old, but you know, so you have to have some hobbies on the side. And for me, for my work-life balance, the 5 days a week with some weekends works better than 7 days, 7 days on, 7 days off. So for me, I find it quite enjoyable.
That's good. It's glad to hear that there's still ways to maintain work-life balance, even when you're on call and have the phone on you.
I think that there's much more of an implementation now, or like a focus on work-life balance for physicians. And there is the Institute for Healthcare Improvement. It's an institution that looks at the quality of care we give in healthcare, because healthcare is known to be the third leading cause of death in the United States. It's just not really monitored. Like, medical errors, if you put it all together, it's really a problem. And so people started looking at quality more. And there's this triple aim of healthcare, right? It should be cost effective, it should be effective for the patient, it should be patient centered. But now there's this element of having clinician satisfaction. That's like the fourth aim. And so as you guys grow up, so to say, through medical school, through residency, you'll see that hospitals are now hiring chief wellness officers, and there's very much a conversation, because burnout costs a lot of money, right? Like replacing a physician costs hundreds of thousands of dollars. And so there's actually, number one, it's the right thing to do. Number two, there's a financial incentive to help reduce burnout.
Okay, so for the next couple of questions, these are more generalized questions. So the first one being, what advice would you have for anyone who wants to pursue a career in neurology?
I would say try to rotate through neurology early and kind of get a sense of what you would like within the specialty of neurology. And then once you realize, oh, I'm interested more in the outpatient movement disorder setting, or I'm interested more in stroke, or more interested in neurocritical care, because there's a wide gamut of what you can do in neurology, from hyper acute to more outpatient based, right? Then you could do electives in that particular specialty. Like during your medical school, I would find a mentor in neurology, like find a physician that you can maybe shadow when you have time, and can talk to them and see what their life is all about. You should probably in some way get involved in some sort of research, to help your application. So, and if you're interested in neurology, I would suggest that you find somebody to shadow, just to kind of see what their day-to-day is like. And then try to get involved in research projects. You can email faculty that you think might be interested in, or might have interesting research going on. I think most people will be pretty responsive. You can ask if you can work on review articles, so some of those or retrospective analyses, those can be low-hanging fruits to have a poster or publication. And you can get involved in your community. So with, for example, your the SIGN initiative, right? You can work with them, and also look for other ways to get involved in the community when it comes to neurology. For example, there are some events in cities, oftentimes for like bicycle helmet safety and things like this, so to kind of protect kids from traumatic brain injury. And those are some ways to get into neurology.
Thank you. That's, I think, very helpful for all of us who are considering this as a field. So next question, what do you think are the major concerns facing the field of neurology today?
So there's not enough neurologists, really there isn't. It's pretty clear that for our outpatient clinic, there's long wait times, right? Patients have to really, if you want to have a new appointment with a neurologist, it might take months in order to get in. And so there's a dearth of neurologists. So you'll be probably never out of a job, which is kind of good news, right? For you, not maybe so good news for the patient, because again, wait times are so long. And then there is this general lack of of general neurologists. And there has been a discussion, as I said, at the AAN, there was a title saying, where have all the general neurologists gone? Because we need more people who want to just do a little bit of everything, because not every patient with seizures needs to be seen by a very specialized epileptologist and wait for months to get in, right? So this access to care when you have a general neurology concern, I think is a little bit of a problem. And finding people who want to do inpatient neurology, like in a role of neurohospitalist, because if their neurohospitalist can really help not just treat the patient, but really lead the team around the patient, right? So the role of the neurohospitalist is to work closely with the nurses, the therapists, and make sure that this patient gets treated in a holistic fashion and then optimized for outpatient care, and that the quality on the service is good. And for that, you need really dedicated people who are inpatient, not just people who do the occasional consult on, on people with neurological disease.
Okay. And on a slightly, I guess, more positive note, how do you think the field of neurology will change in the next 15, 20 years?
So when I started out, people said, oh, neurology, it's diagnose and adios, right? And that is just, I don't think anyone of you will even hear that. So there are now so many therapies that are coming out, that people with MS have multiple options of disease-modifying therapy, right? People with Parkinson have multiple options of medications they can try, plus to know there's a deep brain stimulation path that people can go down. So I think the treatments are just churning out. There are all these new treatments on the market. There are new diagnostic entities on the market, the paraneoplastic and autoimmune illnesses that we are learning more and more about, right? And we're finding more and more factors that can be associated with those illnesses. And so it's like this ever-changing field that really keeps you intellectually engaged throughout your life, because things are always new, things are very complexly changing on a very complex level. So it's just incredibly stimulating and fun. And I think it's just, we can do so much more now for our patients and avoid disability, where in the past we didn't have many tools. So that's exciting.
That's good to hear that we're moving to be able to do more for our patients. So for our last question, this is something we like to ask everyone. What is your favorite part of the brain or central nervous system, and why?
So I would think the frontal lobes, maybe because they help us make who we are and they modulate our emotions. We have the reptile brain, our brainstem, right, that controls our brain, our very basic reflexes. We have our limbic system that like puts us in survival mode, but then we have the frontal lobe who says, you know what, like, let's just think about this for a second. And so I think that is probably my favorite part.
Thank you so much, Dr. Dohle. It was a really pleasure interviewing you today. We appreciate you for your time.
Oh, I appreciate it. Thank you so much. It was a pleasure.